So, it's a pleasure to be here. I've been looking forward to it. So, what I'm going to present now to you now is I think, it will be the easiest to understand talk of the course. And what I have in mind here is to just call your attention to the fact that the working group of cardiovascular pharmacotherapy will be looking into pharmacotherapy in older people. So we plan to launch courses in that field. And I'll be coming back to why we think that that would be appropriate. Then, as a second appetizer, I would love to go through a trial that I have made with a PhD student of mine just a year ago. And contrary to the trials you'll be hearing of in many of the talks today, this was an inexpensive and easy to follow trial, but also a randomized control trial. So it is feasible to do these randomized control trials without having them to be very, very expensive. So that's what you have coming. As mentioned, we are looking into the idea of talking about or teaching cardiovascular pharmacotherapy in older people. And I need to tell you as well that I am not practicing as a cardiologist on a daily basis. I'm practicing as an emergency physician. And in emergency medicine, unfortunately, or not unfortunately, but the reality about emergency medicine is that it's not people who need intubation and cardiac surgery in the emergency department, but it's rather a large quantity of older people who come into hospital and need treatment with polypharmacia and all these other complicating things. So it's a lot of hard work. It's not that sexy, if you will, as one might think it would be. But we'll be talking on the course. We'll be doing how drug is metabolized in older people. We'll look into hyper and hyperkalemia, particularly in patients who receive diuretics. And we'll look into benefit versus drawbacks of blood pressure treatment in older patients. That's also a huge area because guidelines say, or dictate actually, that you need a particular blood pressure in order to not be deemed hypertensive. But older people typically cannot tolerate low blood pressure. They need a higher blood pressure in order to perfuse the brain, and they become dizzy and they fall and they break their hips and so forth. So that we'll be looking into. Then we'll be looking at atrial fibrillation and lipidology and tight glycemic control, pros versus cons. This is again a problem if you have too tight control of type 2 diabetes. You can run into the problem of hypoglycemic events, which is of no benefit to anyone actually. And the older population, it is so actually that tight glycemic control is something you want in order to prevent diabetic complications. But if you have reached an advanced age already, those complications will probably not develop before you actually die. So there's no reason for this tight control. So that we will take that up. And then polypharmacia. But these subjects will be subject to change along the way as well. Any questions to these plans? So this is then the presentation about a randomized control trial that I did with my PhD student, whose name was Camilla Strøm. She was an excellent student and did this trial. And what it's about is actually represented in the slide you see near you. There is a tidal wave of an older population, and that's becoming an increasing problem. As I mentioned to you already, these are the patients that we see in emergency departments day in and day out. And they are very complex patients. They can be patients with a number of diseases, and you need to set their medication straight. You need to treat them, and it will become what is considered a burden for healthcare in the developed countries, at least, for some time to come. So this tidal wave is important, and something that we wanted to address in this talk. So here you see a picture of an emergency department. You see it totally overcrowded, total mess, actually, people running around, patients everywhere. And one thing are conditions that need attention immediately. So all these people are tri-aged, actually. So we know which patients to treat first. So it's not a matter of who came first, it's a matter of who needs attention before others. There's one thing actually that I think is worthwhile mentioning, and that's the problem of frailty in older people. Frailty is a condition in which that even a new medication or that people fall, or minor, or should I say, changes in life can become a major change for these people's lives, the more frail you are. And in emergency departments, you do not score frailty in the older population. I think that's something that one could look into, and that could become perhaps a successful way of evaluating this particular population of older people. Yeah, just another picture from an emergency department, crowded. So anyway, what we wanted to do, or what Camilla did, was actually she looked at a short stay unit that was a part of an emergency department. And the short stay unit was manned by emergency physicians, not internal medicine physicians or surgeons, or not consultants that came from other departments into the emergency department. So emergency department in a secondary hospital, actually, which had its own staff. And so it was a short stay unit composed of 16 beds, but not all of them were beds. 4 of them were actually chairs to seat people in. So there was a fast turnover. And the difference between the regular internal medicine department and the emergency department is actually that diagnostics are fast in the emergency department or short stay unit. A lot of point of care technology is used, ultrasound as well as blood samples. And the length of stay aim was 72 hours. That means that if a patient needed to be hospitalized for more than 72 hours, the patient would still stay in the short stay unit if we were on track with treating the patient. But the aim was 72 hours. So that was what we wanted to assess, because no one really knew before then if older people would be able to tolerate such a setup. One could imagine, or the hypothesis could be, that they would be able to tolerate it. They might even do better, but perhaps they would do worse because of the fast track approach. So that was what we had in mind. So a short stay unit versus usual treatment. And usual treatment, in this case, all these patients were internal medicine patients, and the difference between the setup was that in the usual treatment category, point of care was not something that was used extensively at all. It would take a day or two to get an ordinary X-ray. Blood samples were not point of care either, and there would be another staff of physicians and nurses as well. So the scope was to shed light on advantages and disadvantages by these short stay units of hospitalization of older internal medicine patients. So we were not looking at surgical patients, but internal medicine patients. And because the nurse staffing in a short stay unit is not that extensive, then it was also required that these people who were admitted were ambulatory, that they could take care of going to the bathroom themselves and so forth. The design was single-blinded, meaning that it was impossible to blind for whether the patient was in the short stay unit or in the internal medicine unit. Then it was pragmatic, and by that we mean that it was a real life scenario. That's actually a strength. And it was randomized, controlled, and computer-generated randomization, 1-to-1. And the patients, the attending physician was asked to deem whether the patient was suitable for a short stay unit approach or not. So that was a prerequisite, and the patients were 75 years or older, and they were stable. And the sample size was 430 patients with a power of 90%. So this is an example of a randomized clinical trial with a smaller number of patients, and it didn't cost $50 million to do. So that's the idea behind it. The approvals, of course, as usual, by the Ethical Committee and the Data Protection Agency. The primary outcome, and that I'm happy to say, was mortality. That, as has been said by many of the previous speakers, is the hardest endpoint, in contrast with many so-called surrogate endpoints, because this is something that's patient relevant and something that everybody can understand, that the longer you live, the more benefit you have. But that's, of course, also a difficult endpoint to meet, but that was our primary endpoint. Then we wanted a secondary endpoint to look at changes in daily functional capacity by using Lawton's score, complications during hospitalization, move to nursing home after admittance to hospital, unplanned readmittance, and transfer to another department, which was a triage failure or visitation failure, and then length of stay. So these are the outcomes I'm going to show you in just a minute. So let's look at the results here. First, the baseline characteristics. I'm sorry for the size of the text. There were no main differences between the two groups of patients in the short stay unit or in the internal medicine unit. It's worthwhile noting that the average age was 81 years versus 82. And the number of medications we can look at were more or less the same, about 7 to 8 drugs in each group. Most people were married, and most people also were living in their own home. So the groups were comparable. As for mortality, here you see the difference in mortality, if you can talk about a difference. But you will see that the line above is actually the short stay unit, and below you have the control group, which was the patients who were admitted to the internal medicine department. And there is, of course, a difference, but it does not reach statistical significance. Then you can ask yourself, does that then mean that there is no difference between short stay unit and internal medicine unit? Well, in statistical terms, of course, the answer is yes. But if you look at it from a safety perspective, in safety perspective evaluations, you do not need statistical significance to say that you see a signal. So I believe that this is a signal, actually, that short stay units may even be preferable than regular internal medicine units for this group of patients. If you look at the secondary endpoints we assessed, you can see the difference in short stay unit, which are the dark columns, and the light columns are the internal medicine unit. So overall 90-day mortality, you see as a signal perhaps, but not statistically significant, neither for 90-day nor overall mortality. If you look at the activity of daily life function, there was a statistical significant difference in favor of the short stay unit. And also in favor of the short stay unit, adverse events during hospitalization, change in living facility was not significant, but then again readmission, highly significant, and transfer to other units, significant from the reverse perspective. This is the results of the length of stay, so a clear benefit in short stay unit for this population of patients over or equal to 75 years of age. So let's look at the strength and the drawbacks. The strengths are that it was a randomized trial, that the analyses were blinded, computer randomized, that's also fine, hard primary endpoint, something we are very proud of, and there was 100% follow-up on mortality by tracing the patient's social security number. And then it was a pragmatic design, which means that it was a design that was relevant to what patients actually encounter when they are admitted to hospital. Drawbacks, of course, not blinded for patients or physicians. That would be impossible. And of course, it does not test treatment components because that's not feasible in a pragmatic design. And it does not test complications out of hospital either. Remember, we were following mortality for 90 days and overall mortality as well. So that's what I wanted to show you today. That one, we are going to focus on this population of patients because we find that they are relevant, not least with regard to treating them with pharmacovascular therapy. And this huge burden, if you will, of older patients that will be a problem for healthcare, or at least something that healthcare needs to focus on and address the coming years. And then a pragmatic small trial, which was feasible to carry out expeditiously and without that big a cost.